So this is the final lecture for Immuno. In this one, we're gonna go over all the immune deficiencies and all the physiology slash pathology surrounding these guys. Because I know how confusing it is sometimes to sort of diagnose your way out and like pick and choose exactly which points are most relevant for your diagnosis, right? Apart from that, the diagnosis questions you may see something like um, about the gene or some other like management type of question in step two, but mostly it's just based on diagnosis questions. Okay. All right. So let's get started now. I'm gonna start from the back. Usually, you know how we do immuno. We go through B and T cell disorders and all of that. But I'm gonna start from page 115. We're gonna go through phagocyte dysfunctions first. Okay. So let's understand them. The first one I'm going to pick up is Chidiac-Higashi syndrome. Okay. Now, I've given you the major like sort of thing that you're going to see with all of these phagocyte problems, right? You're going to have to use your CBC. You're going to have to do a peripheral blood smear. You're going to have to do some genetic testing to get what is going on, right? You have to look at what the cells are doing, right? Now, in Chidiac-Higashi syndrome, you have a mutation in the gene called Chidiac-Higashi something, and then other name is the LIST gene. Okay, the LIST gene controls the lysosomal cell trafficking within a cell. Right now, if the lysosomes don't bind to things inside a macrophage or anything like that, they're not going to have any sort of phagocytosis and digestion and stuff like that. Right now, if they don't do that, you see large abnormal intracellular granules are going to be formed, and they're going to have decreased phagocytosis, right? Now, eventually, what this will start leading to, you're going to have immunodeficiency and infections, okay? But the other things that are sort of being affected is, the lysosomal or cell trafficking within all these different cells. For example, your melanocytes, right? The melanocytes, they have melanin, and the melanin is supposed to be deposited and all of that, okay? If they don't do that, they get oculocutaneous albinism, right? You may have silver hair. You may see photosensitivity with these guys. Other thing is coagulation defects. The thing is, the platelets need these cytoskeletal proteins in order to degranulate, right? If they're not degranulating, they're not going to have any coagulation. Okay, so that's another thing that you may see here. Next thing is just disorganization and loss of architecture within the bone marrow, right? Leading to, disorder basically that leads to lymphoma, right? So hemophagocytic lymphohistiocytosis. A lot of fancy words just to say that the architecture within the bone marrow is going to be in disarray. Okay. Next thing is even the cell trafficking molecules in one of the most important cells, which are the neurons, even those are going to be affected. So now what you're going to see, you may see Parkinson's in the patient, some ataxia, some peripheral neuropathy, etc. Okay. Just so we can complete that thought, let's just look over here and what they have. So you see neurodegeneration, lymphohistiocytosis, as I said, in the bone marrow, albinism, infections, and neuropathy. Right? It's hard to remember this, but makes sense of what the root cause is. It's cell trafficking problem. Okay, and then what you start to see giant granules, right? And then if the bone marrow is affected, pancytopenia, and then the coagulation defects, as I explained, right? So if you follow this thought process, you're gonna get the symptoms. You can remember the symptoms better. Okay. Now, couple of diagnosis things that can present with. You see a hair exam, microscopic hair exam. I want to see can the follicles actually mobilize keratin, right? Can they actually have melanin or like make black types of hair, right? Colored hair. That's one of the like special tests or something that you can see in the exam, right? CBC, you see, peripheral blood smear. We've seen this. Bone marrow aspiration can be done, but does there necessarily is just just looking at clinical plus the blood work. Okay, how are you gonna fix it? You see, in any of these immunodeficiencies, the primary go-to drugs are antibiotics. Okay, you have to give them antibiotics, right? Because you need them to fight infection. Apart from that, you might have to do stem cell transplant. Okay, in most of all of these, the general answer is antibiotics and stem cell transplant. Okay, if anything differs from that, then you have to remember them. Okay, so that's one point that you should remember. Now, just so we have good grasp of the whole thing, you see, Melanocyte dysfunction, in the cell trafficking, you see pigmentary changes, platelets, bruising. With all of these cells, you see weak immune response, right? And then eventually, they've given you the different types of like list mutation that can go on and stuff, but you see disease severity increases as you involve more and more immune cells, right? You're gonna see some of these like large granules within the cell. They might give it to you. You see these large granules within the T lymphocytes and stuff. Very, very important. Okay, should be able to identify them, right? Next, we come to chronic granulomatous disease. We in the first lecture we discussed the enzymes and all of that. Okay, so you have to bring that up again. But as we remember, you see all of these are going to be mostly geared towards bacterial infections. Okay, because you're going to use those enzymes to degrade bacteria, right? So any sort of common infection, starting from the esophageal, urethral, cholecystitis, cystitis, right, interstitial or dermatosis, all of these are possible. Okay, it doesn't just have to be upper respiratory infections. Okay, now what are you going to do for treatment? Treatment is just based on antibiotics again, and if you have fungal infections, you can give antifungals. But usually, what you can do is immunomodulatory. Try to get the T cells and B cells working. Even though the phagocytes aren't working, you can still mount some sort of response. Okay, so that is the principle of these, right? So we just take a look at this chronic granulomatous disease. You see, because you're not degrading these particles, these bacterial particles, what are you going to do? You're going to wall them off, right? That's where you're going to form granulomas, right? And usually, if you remember, granulomas are formed with Th1 cells mostly. Okay, they're the cells responsible. Okay, they've given you a couple of tests. One of them being the flow cytometry test, right? The other one being this dihydrorhodamine thing, right? Now, the thing is, the dihydrorhodamine. Remember what's happening in this condition, because you don't have the enzyme working, the enzyme cannot convert the fluorescent dye into something that actually lights up. Okay, so when they say the dihydroamine test is positive, positive test means there's negative, there's no fluorescence happening. Okay, it's still dimly lit. Okay, that's what this means. Sometimes a lot of people get confused. Well, dihydroamine test is positive, which means they must be lighting up, right? In most of these fluorescent tests, it's like something lights up, but in this case, it's not lighting up, right? So that's the like a couple like a mental mistake a lot of people do. Next thing is this nitroblue tetrazolium test. Usually fails to turn blue. Again, the colors are not changing into what they're supposed to. That's the key. Okay. All right. Now this is a good like representation of all the things that are happening. You see, most of the bacterial infections, right? So categorize all of them. Osteomyelitis, you see urinary tract infections can be involved. You see gastrointestinal granulomas can be formed. Hepatomegaly or liver abscesses or pneumonia, and then maybe some type of chronic anemia and stuff like that, right? So all of those are going to be important, right? Now, treatment, as I said, it can be like avoid the live vaccines, inflammatory manifestations. You might have to give them glucocorticoids to just suppress the inflammation, right? And you might need to do like a stem cell transplant again to sort of fix this. Okay. Now, next comes leukocyte adhesion deficiency. Important, right? Now, LAD, if you look at in the first aid, they just talk about type 1. Okay. They don't talk about the two other types. But for us, as good students, we're going to have to remember the difference between 2 and 3. Okay. So what we're going to do is we're going to look at how each of them work, right? And to do that, we have to look at the attachment and migration of lymphocytes and other immune cells into the tissue, right? The page you're going to refer to, if you're using just your first aid, you're going to have to go to path and go to page 211. Okay. Now, within this diagram, you see there's a lot of things to remember, right? So we're going to have to sort of make sense out of all of these so you can remember it better, right? Now I found an even better diagram, and we're going to use sort of this to actually help us understand and remember. Okay, so you see there's 1, 2, 3, 4, 5 stages. Okay, 5 stages, right? Only one of the stages is maintained by selectins, right? All the other stages after that is just integrin mediated, right? So if you can just remember, where are selectins seen? right? In the rolling phase, right? There's a slow rolling, there's a fast rolling, and then a slow rolling, right? In the slow rolling phase, you only see the selectins, right? Now you see there's two types of selectins, right? There's the p-selectin and then there's the e-selectin, right? And then once you sort of come here, you see how what the difference between the two are, right? E-selectins are generally, upregulated by inflammatory cascades. Okay, so whenever there is some sort of inflammation happening within the tissue, E-selectins are going to be higher. Okay, P-selectins are sort of beneath the endothelial surface and within these bodies called weevil palate bodies. Okay, right underneath you remember how like if there is endothelial damage there's von Willebrand factor, right? It's basically that's where these guys are too, they're too. Okay, so p-selectins are usually in the endothelial surface, usually in these bodies, and there's and they're excreted. Okay, that's the difference between E and p-selectins, right? And then there's a couple of other ones that they've written in here, glycam and CD34, all of them still selectins. Okay, now, the selectins are basically slowing down, and imagine like a plane landing and going into the hangar, right? The plane lands as soon as it touches down. It usually lands using selectins, right? Once it's done like rolling, right, and it comes to an arrest, now you're in integrin domain. Okay, what is the integrins going to do, or which integrins are going to be involved? You're going to see the ICAM and the VCAM, right? And both of them are basically very, very high numbers, 54 and 106, right? If you remember CD55, right, make sure you understand the series of things. CD55 was the thing that we were looking at in complement, right? Complement, and I think it was decay acceleration factor, right? But there is this one here is 54, which is a very high number, and you see it in the integrin section in the adhesion parts of the um, hemostaxis. Okay. So CD54, again, the second high number is 106, right? VCAM is 106. Now, the thing is, this is on the landing surface, right? But the plane, which is the cell, has these markers on it, right? CD11 slash 18, and then VLA4. All of these are integrins too, right? Even these are sort of like selectins. So E-selectin binds to silyl Lewis X, P-selectin binds to silyl Lewis X, glycam and CD34 binds to L-selectin, right? So the plane has this, and the landing strip has this. Okay, so the landing strip has these heavy numbers, but the plane itself is binding via CD18. I think that one has to be the main one that you have to remember. Okay, so now the integrins have attached here, right? And now you go into adhesion, right? Adhesion means, you know, you have to sort of bind it enough to say that, I'm ready to go inside the tissue. Okay. So adhesion and then crawling and then eventually migration. So let's look at all of this. So you see diapedesis, or sorry, adhesion, we sort of did this adhesion part, but now you come into diapedesis, which is transmigration, right? Actually going in the tissue. These are handled by PCAM, right? PCAM. PCAM has CD31, comparing it to CD34, right? That's the like a common mental mistake that people make, right? So CD31 is the last thing that they're going to join, and both of them have the same sort of molecule. And once these are joining, and they will basically, allow these things to go through the cell, right? Now, a couple of questions that sort of, stem from this, right? A lot of cancer cells, if they want to metastasize, right, they want to go from tissue to inside the vascular, endothelium and inside the lumen of the vascular system. They're basically going to reverse all of this, right? You have to make sense of that. Cancer cells want to metastasize, they want to escape. So basically, they must have, bodies which basically resemble these proteins, so they can make their way through the endothelium and go inside these cells, the blood, the vascular system. Okay, so for example, sometimes they say that the cancer cells have something called integrins, right? So there's integrins that binds cells with cells. Okay, so two cells can be bound by integrins, right? A lot of these cancer cells, they say the integrin, quantity on that cell is decreased, which means they can go slipping in and out of cell boundaries and go into the endothelium and go there, right? So sometimes they like to ask all of these, or there's also got these protein called adherents, right? I think it's adherents, these E adherents, and all of that. All of that means that the cancer cell can freely go in and out as they please, right? So that's another sort of question that we see. And you see the cadherin over here, the PCAM over here. There's some more CD markers, but that's the end of LAD, right? Now let's understand, and there's another sort of diagram that I'm going to use later, but let's understand what is type 1, type 2, and type 3. Okay, type 1, as you see in the diagram, is or in the first state you see is integrin beta 2 gene is going to be mutated, right? Sometimes they might bring this up, so we're going to underline it, okay? Because understanding type 1, since it's in the first aid, means it's been asked more times, right? So you have to start to remember what are the genes involved and stuff like that, of the things that have been asked more, right? So beta 2 integrin gene, right, which is, if it's mutated, then you cannot form the CD18 unit, right? And where's the CD18 unit? This one, okay? So CD18 is not working. All right, we got that. Now, if CD18 does not work, which steps are going to be lost? Adhesion, and there's the following step, the transmigration, not going to occur anymore, okay? So what are you going to have? The main sort of focus that they want you to keep on for type 1 sort of phenomena is soft tissue infections. Okay, that's the main crux of the whole type 1. Okay, recurrent soft tissue infection, right? And we understood why. This is usually the CD18 domain, okay, adhesion part. Type 2 is a defect in the GDP fucose transporter, okay? The thing is, if this gene is lost, you cannot make any selectins anymore. And if selectins are not there, what is going to happen? No rolling, no further migration, all of that, right? So you see, usually type 2 is over here, okay? Type 1 is over here, type 2 is over here, right? Now, if you do that, and then you see, the thing is, with these types of type 2, LED type 2, the main thing that they would like to focus on is psychomotor stuff, okay? And I'm pretty sure it's just linked to like how microglial cells work and how they, sort of go about in the neuron and stuff like that. But just for exam purpose, remember that whenever they ask a question about LED type 2, they're gonna have to put something about psychology and psychomotor symptoms and stuff. Okay. Next comes type 3. I've given you the gene. It's the calcium DAG gene. I think it's more like a GQ pathway thing, right? Then you have a beta integrin problem, right? So what's happening here is there's no adherence that's going to happen. Again, the first, sort of area. But then you see that there's no platelet aggregation. There's no natural killer cell functioning, right? And here, the main thing is that they like to focus on is bleeding complications, okay? Because the platelets are not going to be adhered to themselves and even the endothelium. That's the main thing that they're going for in type 3, okay? I expand upon this in using this table, and then I've highlighted exactly which ones are going to be asked the most and which one's the hallmark, right? For example, recurrent infections, LAD type 1, main, okay? Gingivitis, peritonitis, you see, you can see it in, LAD2, 1 and 2, but mostly it's geared towards 1, right? Skin infections, again, LAD1, right, compared to the others. But now you see delayed umbilical cord separation, omphalitis, LED1, some parts of LED3, right? But LED1 mostly. Inability to form pus at injury and infection of site, mostly LED1. Okay. Now impaired wound healing, still LED1. But bleeding tendencies, LED3. Okay. Motor and intellectual delay, that's gonna be LED2. That's the main thing. Okay, that's what we're looking for. Right? 1, 2, and 3, know the difference. Right? And just like as a summary, just this is another diagram which we can use. You see, LED2 is early, right? LED2, and they've given you the P selectins and E selectins, and I'll try to zoom in just a bit more here. And then VCAM and ICAM come in, right? And then ICAM and eventually turns into the PCAM that you can see here. And eventually, you see they have to go in and activate a couple of enzymes to sort of degrade like the matrix within the cells. For example, there's collagen 4, there's different things, and they have to degrade using metalloproteinases, elastase, and degrade some of the extracellular matrix to actually make their way through, right? So, that's a couple more things, but, we don't need to get into that. But you see PCAMs and stuff happening here as well, right? So LED type 1, if they definitely want to go further into like these stages and stuff, one is usually in the arrest phase, so it means it's completely stops. LED 3 is usually in the activation phase, is after rolling, right? So immediately after rolling, it's the LED type 3. Okay, 2, 3, and 1. If you can remember that, or at least 2 and 1, remember that. Okay. All right, so that one is LAD, and we can sort of go back into immuno and just look at the section. Okay. Okay. So chemostaxis, remember the things that call for these cells are also important. Okay. These are the things that will increase the expression of different selectins and integrins on the endothelial cells and even in the immune cells, right? Now, one thing they ask, and the next sort of diagnosis point there is that if these cells cannot escape into the tissue, right? What are you going to have in the peripheral blood smear? You're going to have high amounts of WBCs, right? High amounts of WBCs, despite the person having an infection, right? Despite the person, you see, the differential is whenever you have high WBCs, what are you going to think of? You're going to be like, well, this person has an infection because they have high WBCs, right? Or this person has leukemia, lymphoma, something like that, right? But the thing is, you have to understand that they they can undergo like action via certain like tissue cells and stuff, right? They can phagocytose and stuff, but any other help is not going to happen. Okay, so they can mount like sort of inflammatory things, but and secrete all these cytokines and stuff, but they're not going to have any actual action happening against them. Okay, next set of like diagnostic points that they might bring up: flow cytometry, right? You see LED1, which we saw, right? It says CD18. You see CD18, right? CD18 is going to be lost. Another couple of things that can be lost: CD11. All types of CD11 can be lost, right? It's the same thing. CD11 slash 18, if you remember that first aid diagram, right? Page 211. Genetic testing for GDP fucose. If that is lost, then it's type 2. Impaired integrin activation, you see that was in the activation phase over here. If that's not happening, it's LD type 3. All right. Now, looking at the treatment, antibiotics, you have to give them something to fight the infection, right? Monitor their oral hygiene. It's a common question to be asked when you have like periodontitis or some other like mucosal inflammation. You have to fix those infections first. Sometimes you may need to drain some abscess or do something, right? Fuco supplementation for these guys, LED type 2, and stem cell therapy in general for all of these guys. Okay. So now we just finished these three disorders. It should make sense. You should once you understand the whole cascade, you should start to differentiate amongst these three. Okay, and if you see the questions, you'll definitely start to remember why. Okay. Now we get into T cell disorders, right? T cell disorders only, right? So you see, you have four disorders here: thymic, IL-12, IgE, and chronic cutaneous candidiasis. The thing is, in my notes, I haven't covered all of these four. I've only focused on IgE and DiGeorge. Okay, the other ones we're gonna do right here. So let's start with IL-12. Okay, now IL-12 or even IL-2 is very very important for what Th1 or Th activation in general, right? If those are not working, right, and because of this autosomal recessive, you see most of these receptor deficiency is mostly an autosomal recessive thing, right? If those are not working, you're not going to form, and if Th1 is not working, you're not going to form any granulomas, right? And if you don't form any granulomas, what are you going to have? Anything that was supposed to be contained cannot be contained anymore, right? So one of the most important things that you sort of contain is mycobacterium, right? You contain it until you know you die, right? So mycobacterium, fungal infections, they cannot be contained anymore, and they become very, very disseminated. Okay. Now we understand TB, but understand what leprosy is sort of doing too. Okay. So let me take a second here to explain like leprosy and how it works. If I haven't done it individually, leprosy, you will. All right, so I'm gonna put this in my notes too. But remember what is sort of happening here. So remember that there's two types of leprosy. Okay, there's the tuberculoid type and there is the lepromatous type, right? Tuberculoid type is much more milder in presentation. It has less like disfiguring symptoms and stuff, right? Whereas the lepromatous type has very, very intense, like, skin findings, neural findings, and a lot of like disfiguration. Okay. But when you look at tuberculoid, it's going to be mild, like, papular inflammation or something. Okay. Now, the reason why this sort of happens in different individuals is because different individuals have different types of immune activation. Okay. So you see, here are the two different types of leprosy, right? Tuberculoid basically goes under Th1 response. Th1 can sort of contain the leprosy within these intracellular, because you see, Mycobacterium is intracellular bacteria, right? Tuberculoid and Th1 response contains it, right? Makes granulomas and contains it, right? And that's why when you have a Th1 response, you can get a lepromin skin test positive. Important. Okay, that's the only way you can get a lepromin skin test positive. Compare that to something like PPD testing, right? That is more of like a hypersensitivity type 4 reaction where you're getting the T cells and mounting a response against those antigens. It's a similar sort of setup, right? Here is the lepromin protein, right? And then your T cells are going to recognize it and they're going to have to mount a response. It's the same sort of thing, okay? So that is a tuberculoid type, gives you mild symptoms, right? But then, if your Th1 response isn't that great, or if the bacterial load is increasing in quantity, right? Then you're going to have to or sort of shift, or naturally you start to shift to humoral immunity, which just means antibodies, right? Here you're going to start to see Th2 response. Now, because the cell-mediated response is lost, you cannot mount any skin test. It's all going to be negative. Okay, and then you start to see that the leprosy has become more and more disfiguring, involving neurons, debilitating and all of that. Okay, so those are the two difference. I encourage you to look at the patients, how they look. You see, this is more of like lepromatous leprosy. Okay, used to be a big problem back in the day, right? So look at how all of these sort of see in this, right? Now coming back to this, you see if those mycobacterial diseases, or if they ever try to correlate IL-12 and mycobacterium, you're ready. Okay. You see, even after BCG vaccine, right? BCG vaccine is meant for TB, right? Even after the vaccine, you can have disseminated sort of TB, right? Even though it's a kill vaccine, you can see disseminated sort of presentation of TB. Important. Okay, now we understand this. Next comes the T cell dysfunction for chronic mucocutaneous candidiasis. It's in the name, CMC, right? It's in the name. T cells are supposed to protect against funguses, right? And because the T cells are not actually, functional, why aren't they functional? Because this AIRE gene, right? This AIR gene was supposed to do the positive and the negative selections, right? But this AIR gene wasn't actually working, and now you get all of this T cell dysfunction, right? And if I just show you, you'll remember it better. The page is, where did it go? Yeah, here, the AIR protein, right? Drives negative selection and deficiency leads to. So deficiency leads to this, and then AIR mutation leads to the CMC. Okay. Now, candidas are going to be while spreading, and you have infections of skin. You can have disseminated candida infections. It's only for candida. Okay. So absent cutaneous reactions to candida as well, right? So you're not going to mount any response because your T cells are not working. All right. Now comes, let's do thymic aplasia, DeGeorge, and then we'll go into Job. All right. Now, DeGeorge. You see, if you can sort of figure your way out with all the different systems that are involved in DeGeorge, right? You can understand and not forget about what's going on. Okay. So first thing that is going to be, characteristically involved is the face, okay? Because the pharyngeal pouches, the third and the fourth pharyngeal pouch, it's the problem is there, right? And just to show you the the developmental process of these three, the pouch 3 and 4, let me go into repro. I'm going to give you the pages which you can sort of read as we go along this part. Yeah. So you see, let me just give you a quick overview of the pouches and stuff. Pharyngeal apparatus. For some people, it'll be a review, but it's important to remember these from time to time, right? Pouches are the inside. Okay, so they're mostly made of endoderm stuff. Okay, arches are these like string beans. These beans which are inside the tissue. Okay, which the in the arch each contains parts of the mesoderm and usually neural crest, right? And it's all written here, right? And then the clefts are the ectodermal part of it. Okay, so when they say third and fourth pouch, they're usually just talking about this and this part, right? Now, cleft have their derivatives and problems, pouches have their derivatives and problems, and then you come down here, the arches will have their derivatives and problems. I'm not going to go into the clefts and arches, right? We're just going to look at third and fourth pharyngeal pouch, okay? Now, remember that there's different types of wings when it comes to pharyngeal. Let me just show you pharyngeal pouches. So we see here, right, the pharyngeal pouch 3 and the pharyngeal pouch 4, right? The interesting thing and the thing we have to remember that even though, you know, embryologically initially, the pharyngeal pouch 3 is on the top, and the thing is, this gives rise to the inferior parathyroid glands, as you see in this diagram here, right? Now, where are these inferior parathyroid glands made from? The dorsal wings, which means, posteriorly, right? Posteriorly located wings, right? Versus the ventral wings, which actually give rise to the thymus. Okay, important, right? Because if there's a dysfunction of either of these, you see the parathyroid gland is going to be involved and the thymus gland is going to be involved, right? That is what DiGeorge is, right? So it's important to visualize and see what's happening and, come back to this page. This page is 637 and read exactly what sort of is happening. Read about first and second pouches too, okay? All right, so now we can sort of go back and figure out all these defects, okay? Now, it's not just, I didn't show you the arterial problems, but arterial embryology and stuff. But remember that there is an aortic arch as well, right? Even that depends on the the working of these pharyngeal pouches 3 and 4, right? If those are going to be problematic, then you're going to have some cardiac defects within the child too. Okay, truncus arteriosus, tetralogy of Fallot. You see, this one is the most common one, in at least in the questions ones. Okay, thymus gland abnormalities. You're going to see skid eventually, right? Now, because you see, as they grow up, they might have some other genetic problems. One of them being like mental problems, right? Learning difficulties, or maybe schizophrenia. And because the parathyroid have not developed properly, you see, hypocalcemia, and then that leads to hyperactivity symptoms like seizures, tetany, maybe even osteoporosis and stuff. Okay, because you don't have enough parathyroid. Okay. Now, this is a typical phase of how the child might present with, right? So you see, there's large distance between the eyes, right? The eyes, and look at the ears. There's low set ears, right? If I draw a line from the eye to the back side of the head, at least, you will see that the eyes are low, right? You see the oral um, diameter is not enough, right? They're small, right? Broad noses, right? So that's the usual typical physical presentation that DeGeorge might show up with. But trust me, they're not gonna have just physical, photos or descriptions like this. They're gonna have something, at least one thing they're gonna give you to make sure you can diagnose by like DeGeorge syndrome and stuff. Okay. All right. So that's that. Let me just see if we've covered all the things from our book, right? So you see, they've called it two different things. If it's velocardiofacial, you're gonna see the palate, face, and the cardiac defects, right? And then remember, diagnosis is always gonna start with like chest X-ray, right? Thymic shadow in chest X-ray is gonna be lost. Sometimes they love to ask or word it in different ways. They're going to say there's something missing in the anterior mediastinum, right? Be cognizant of how they like to term these things, right? Try to figure out what are they actually saying when they say this line. Okay, that's how they're sort of asking these questions now, right? Now, so we did DiGeorge syndrome. Let's go into hyper IgE. The way I've structured this is kind of different. Um, I put the cellular disorders up here, and then I put the like antibody disorders down here, right? So when you do see this, it might be confusing, but just follow the first aid and then come back here, or otherwise you can just follow my stuff. All right. Now, IgE, hyper IgE syndrome or Job syndrome, right? The thing is, we don't actually know the etiology of all of this, right? We don't know why it sort of happens. In the book, it's given as Th17 response and the STAT3 mutation and stuff, and you may see like recruitment of neutrophils and things. But the thing is, the the exact sort of like genetic problem, and it might be it might be a couple of different theories that are going on. Okay, so it's rare to see it, right? But what are you going to see in the patient? You're going to see skin/respiratory infections. You're going to see eczema. That's one of the main things. You're going to see that they have eczema and they're itching, and they have high IgE levels, right? High IgE levels. Usually the patient is going to be a newborn, right? The newborn, the first thing that they present with is a rash, right? And the rash is basically like impetigo slash boils kind of a thing, right? Eventually, it might turn into like a staph, skin abscess kind of a thing. And usually it's cold because you're not recruiting the neutrophils to work, right? And the skin abscesses can also lead to some or translate into something like respiratory infections, right? So you're dealing with a small child, right? And they're showing up with continuous spectrum of infections, right? The other kind of a thing that you might see in these kinds of individuals, you see there's connective tissue problems, right? Usually you don't see connective tissue problems with any of these immunodeficiencies, right? But here you might see that they have hyperextensible joints, similar to Ehlers-Danlos, Marfan, all of that, right? But in this case, you're going to have the infections plus joint problems, okay? Here, because of these connective tissue problems, you'll start to see retained teeth, right? Coarse facial features like developmental abnormalities, right? Um, Maybe the stump that was supposed to fall post birth has not been, cannot be excised out, right? So that's the usual set of symptoms. And the next thing is, if constantly repeated with all of these, hyper IgE stuff, you may start to see malignancies, mostly like leukemia, lymphoma, or you might start to see autoimmune, for example, RA, SLE. The more you sort of start producing these aberrant cells, eventually, as adults, they might contract these different malignancies. Okay, so let's just make sure we covered all the points here. You see, cold abscesses, right? Retained baby teeth, or teeth. All of these are connective tissue problems, right? Derm problems are the first thing that is going to show in the newborn baby, right? IgE and then bone fractures and from minor trauma and stuff. Again, connective tissue problems, right? So you're gonna see this like hyperextensible baby or baby with multiple fractures. And then you're gonna feel like, wait, why is this earlier downloads kind of a scenario looking like, right? And then they talk about maybe like the eczema and stuff like that, and you're like, okay, just leave that. Let me just go with earlier downloads, right? So that's how they sort of confuse you with these things, right? And then yeah, so IgE and eosinophils are going to be high. Okay. At least for the exam, try to remember Th17 and the relation between neutrophils and stuff, and how do they actually get there? The JAK-STAT pathway. Okay. The treatment, right? Treatment is give them antibiotics. One of the main antibiotics that you can use for these types of bacteria and stuff is TMP-SMX, right? Do surgery for the abscess, perform skin care, right? Make sure they have all the necessary emollients and stuff to actually not dry their skin out. Okay, give them antibiotics for respiratory infections. That's the main thing, right? It's just antibiotics over and over, right? Eventually, they will need the stem cell therapy. Okay, so that is Job syndrome. All right, so now we finished all the T cell disorders. Now we're going to look at just the B cell disorders. So there's three over here. So Bruton's, selective IgA, and CVID. All right, so let's look at that. So we're going to go to ataxia later. SCID. Yeah, let's do CVID first. Okay, CVID is right here. Okay, so defects in B cell differentiation. Now I've given you a little bit more about what sort of defects they're talking about. Okay, now first thing is the patient is usually 2 years old. Okay, greater than 2 years old. You see, I've given you all of these points because sometimes the age also matters, right? How early are you actually presenting with the immunodeficiency, right? It can be a newborn like in Job syndrome, or it can be a 2-year-old in the CVID. Okay, so what is actually happening? There might be intrinsic defects within the B cell. There might be a problem with the activating factor of the B cell, right? Or it might be a problem with the cytokine co-stimulator, right? Which is basically responsible for stimulating B cells, right? But in all these three cases, the core idea is B cell dysfunction, right? If B cell dysfunction happens, the first thing is it's mostly asymptomatic initially, right? At least initially it's going to be mostly asymptomatic. But then eventually what it's going to start to happen because you don't have any sort of, protection, you start to get infections. Now, because you have caused B cell aberrancy, right? B cell dysfunction, eventually it will translate into autoimmune diseases. The most common, just remember at least SLE, right? SLE-like features, okay? Next, you might start to see some chronic diarrhea, okay? Because GI infections and just GI management with like the E. coli, the microbes that are already present there, that has to be managed too with the immune system, right? But there is no sort of activation between and communication between these guys, okay? So chronic diarrhea is a problem. Hepatosplenomegaly, right? Or failure to thrive for the child itself, okay? So all of these are happening because B cells have refused to work now. Okay, common variable, immunodeficiency. Now, you see, eventually I've written autoimmune, you see rheumatoid arthritis, autoimmune hemolytic anemia. With lymphoid malignancies, you might see gastric cancer, right? That might come up. Eventually, within the respiratory system, you might see bronchiectasis, right? You might see some granulomas because all the T cells can do is sort of give you granulomas, right? So your cell-mediated immunity is still working, but your humoral immunity is completely shot, okay? So what's going to happen? All the immunoglobulins are decreased. How are you going to test them? Usually genetic testing. And then just to confirm we've gotten everything, you see, risk of autoimmune diseases, infections, lymphoma, everything increases, right? Because of the B cell problem. Okay? And plasma cells and immunoglobulins are low. That is CVID. Okay? What do you do? First of all, to make sure you're not just having constant autoimmunity, you're going to give them immunosuppressants, right? To make sure they don't have constant infections, you're going to give them antibiotics, right? What you can also do is you can give them IVIG, IVI, IgA, IgM, all of that. So you can do immunoglobulins replacement therapy. That is a thing. Okay, you can give it to them, sort of restore some of the functioning of the immune system. Okay, so CVID is sort of manageable, right? Next comes selective IgA deficiency. This one is one of the more easy ones. What you'll see here is that IgA, which is basically the first innate immunity sort of barrier to mucosal surfaces, those are being lost. Okay, how old is the kid? The kid is pretty old now. It's usually greater than 4 years old. Okay, greater than 4 years old, the child will start to present with mucosal infections. Okay, mouth, GI, all those, even the respiratory stuff, all of those are going to be seen. Okay, they might start to show autoimmune phenomena too. Okay, eventually they will start to show autoimmune phenomena. The main thing is GI infections, diarrhea, main thing. Okay, the next couple of things will be allergic disorders because not having IgA can sort of precipitate this whole allergic atopic phenomena. Okay, and then anaphylactic reactions to blood products. We sort of saw this when we did like the transfusion reactions, right? The IgA deficient person receiving blood from a IgA normal person. That's gonna cause anaphylaxis. Okay, so IgA deficiency. So you just look at all of these. See, asymptomatic usually, but it can go into airway, atopy, anaphylaxis, and autoimmune. Okay. The one, like sort of special point that they like to ask is, can cause false negative celiac and pregnancy test. That's or sorry, just celiac, false positive pregnancy test, right? Understand this one more than the pregnancy test. Understand this. You see, celiac disease has IgA mediated action, right? IgA against transglutaminase and all of that. Okay. If you have IgA deficiency, you're not going to make those sort of antibodies, and you may not be able to detect those antibodies, right? But they're there, they're causing harm, but you may not be able to detect them, right? So that's what the false negative is for. So a person can have celiac disease and have IgA deficiencies. That's the core. Okay. All right. So how are you going to manage them? Antibiotics for their infections, anti-inflammatory for their autoimmune diseases, right? And antihistamines for general like anaphylactic reaction or anything like that. Okay. So I hope I've covered all of this. Now comes X-linked or Bruton's A gamma globulinemia, right? Now, if you look at this, they've given you the gene, the BTK gene, okay? I don't think they've mentioned the chromosome. I think it's might be 11 or 6 or something. Just look for that one. But once this BTK gene is not working, right? You get immunoglobulins completely shot, right? But the T cells are sort of still working, right? The T cells protect you against viral, fungal, protozoals, slightly, right? At least slightly. So they're still slightly working. But you see, bacterial infections, they're not very well managed. Okay, so bacterial infections are very, very more common in this BTK, Bruton A gamma globulinemia, than the other ones, right? But you can see viral, you can see fungal, but bacterial infections are going to be the most common one. Okay, you see, recurrent bacterial or some enteroviral infections. Okay, now next thing that I have to discuss is that when does it happen? You see, newborns are asymptomatic, okay, because of maternal Igs. So it takes at least 3 to 4, maybe 6 months to get all the maternal immunoglobulins, completely ending, completely finished from the baby, right? Um, so until then, the baby is protected from the because of the maternal immunoglobulins. Once that is finished, then the baby's turn it's the baby's turn to actually make these immunoglobulins, and if they don't do that, then you have a problem. Okay. Now another sort of thing that they like to ask, you see, this is an X-linked phenomenon. Females have two X chromosomes, males have one X chromosome, right? So it's much more common in a male baby to show this type of phenomena. Okay, that should make sense, right? So that's the main thing. And then you see everything is lost. You have absent or scanty lymph nodes and tonsils because there's no germinal centers, right? And of course, with most of these cell disorders, immunodeficiencies, live vaccines you cannot give it to them. Okay, they're gonna turn back to life and just destroy. Okay. Now, one other thing that I found was this diagnosis of transient low immunoglobulin of infancy. Okay. The thing is, it's a good thing to ask and compare between these two things, between Bruton and transient. Okay, you see, when the maternal Igs diminish, that as we talked about, you see, sometimes the baby does not start to produce their own Igs. Okay, when is it a problem? If it has become more than 6 months and the baby still hasn't had enough IgGs, right? Then it's called the transient decrease in of immunoglobulins in infancy. Okay, now the thing is, usually the function returns back to the child by 4 years of age. Okay, usually it's just seeing that, what, we recognize that the baby does not have any immunoglobulins, but eventually it will come back. Okay, but if it's really persistent and stays throughout the life, then you might categorize the diagnosis as maybe like BTK mutation or something, right? If it's not there, usually, you just keep this and, just classify them as like some sort of immune deficiency. Okay. And then how are you going to treat these guys? IG replacement therapy, but usually you wait it out. The treatment is waited out. Okay. The thing is, this is a diagnosis of exclusion. So you have to do every workup you can, and then you can arrive to transient, low immunoglobulins of infancy. Okay, and up until then, you should have a different differential going, right? But this is, you might see this in the options, you might see them like a simple question in step 2, because they love to, test your patience. Are you going to sit for this patient, or are you going to do something for this patient? That's like the question that they like to ask, right? So that's what we're going with. Okay. Usually, the patient's IgG levels are usually less than 2 standard deviations. Okay, so it's like, imagine the developmental milestones. Even the immunologic milestone has not been reached. So it's just like, they're slow milestone for the immune system. Okay, so that is BTK, right? Bruton's agammaglobulinemia, right? Now, all that we're left with is B and T cell disorders: SCID, ataxia, hyper IgM, and visceral Eldridge, right? A lot of people just get confused with these things. So we're going to work them out individually, and we're going to work them out well. Now, first thing is, let's look at SCID. Where is this SCID? Here's SCID, okay? What is the typical presentation? Infection plus rash, right? When you study this, all the places where it says rash, write it down, right? Infection plus rash equals dash dash dash. One of them being SCID, one of them being like the hyper IgE, and the other one, I think it was the maybe one of the phagocyte disorders, right? So write those things down, right? But that's gonna help you narrow, or influence your probability for a differential. Okay. Um, so infectious, then rash plus diarrhea. Okay. And then you look at the counts, the different cell counts. T cell is going to be low, natural killer is going to be low, B lymphocyte can be normal, can be low, right? But there's, might not be any IgG synthesis or Ig immunoglobulins synthesis properly, right? So that's the typical presentation. You see, infection, rash, and diarrhea, T and B cells being low, okay, or dysfunctioning, right? Now, why is this happening? They've given you 3 reasons here. In the first aid, they've given you 3 reasons: IL-2 receptor, ADA deficiency, and then RAG mutation. Okay. Now, the most common one, and the one we're going to discuss first, is this ADA deficiency. Okay. As I said, the deficiency is because of autosomal recessive conditions, right? Recessive is just a common thing for deficiency. This leads to ADA not working properly, leading to accumulation of metabolites, right? So if you look at how ADA sort of works, adenosine deaminase mechanism, right? So let's see. And I'm sort of going to use the first aid too, but I just want us to have like a good working diagram. Yeah, let's do this one. All right, so this is what is ADA sort of supposed to do, right? It's supposed to take, you see, it's in the name, deaminase. Deaminase. Take out the amine group. Deaminase. Okay? So it turns deoxyadenosine into deoxyinosine by deaminating it. And this inosine, right, is supposed to go into either uric acid, or is supposed to be reabsorbed and used, recycled back with the cell, right? If you're not doing this deaminase, eventually you're going to start to make all these, start to degrade and not have enough AMP, ADP, ATP, nothing, right? And eventually it's going to become in this deoxy triphosphate, right? Now this is the problem. This, you just created a poison, okay? Now this poison will cause lymphotoxicity. So important thing, right? And I'm going to show you this in the first aid, right? Going into biochemistry, and page is the first few pages, page 35. Okay, so you see ADA deficiency right here. Okay, SCID right here. So the adenosine is not getting converted into inosine, and then inosine was supposed to go into hypoxanthine and all of that, make uric acid, or it can be go into hypoxanthine and make IMP, right? Make IMP, and that this can be used into GMP and make all these guanosine, guanine, all these nucleic acids that can go in back into the DNA of something, right? But you're not making this anymore, right? And that's the problem. Now they've given you 2 drugs which you can start to correlate right now: cladribine and pentostatin. Okay, cladribine and pentostatin are trying to suppress the immune system via T cells. That's what they're doing, cladribine and pentostatin, right? They're inhibiting the immune system via ADA mechanism. Okay, so important drugs which you can sort of look up in the first aid. You should look up in the first aid, right? Where are they being used? Why are they being used? What are their function? Okay, so ADA is the main thing, right? So let's get back into immuno. Right. So we first perform the ADA stuff, right? So now we're gonna come back here. Just look at all of these. Accumulation of the triphosphate metabolites leads to SCID plus neuro stuff. That's the important thing. Okay, when you have ADA deficiency, you might have to look out for neuro things. What are those neuro stuff? Gait problems. They can have difficulty walking, balancing, and things, or cognitive slash behavioral problems. But something neuro might be given to you in the question. Okay, if they're specifically asking for EDA deficiency. Okay. Otherwise, what they can ask for is the cytokine receptor deficiency, which is the IL-2 receptor, right? If IL-2 does not work, IL-2 was supposed to say, divide, proliferate, survive, right? But you're not going to do that anymore. Okay. The last one was the RAG mutation, right? RAG mutation was supposed to give you somatic hypermutation, allow the T cells to have more antigen affinity and all of that, right? Supposed to help them also flourish and grow and grow in number, right? Not gonna happen anymore. Okay. And what is this all leading up to? Whatever the T cells were supposed to do, the B cells were supposed to do, not working. So a lot of opportunistic infections are going to come in through, right? Candida, pneumocystis. You're going to see the Pseudomonas infections being common. CMV, varicella, very, very common stuff. Okay. Mostly, they've given you all these bacterial, fungal, and protozoal. This is not going to help you in diagnosis. Okay, they've given you all these three, but they're not going to help you in diagnosis. The diagnosis is going to be made by what is the etiology and what is the genetics slash what is the diagnosis like test that they've done. Okay, usually does not help you too much. Okay, apart from maybe like Candida, which is just seen in like CMC. Okay, usually this does not help you. But you see, chest X-ray, lymph node biopsy, T cell flow cytometry, right? We've seen all this, and it makes sense. You want to get the biopsy of the lymph node. You want to get the cells which are there by flow cytometry, and do they have enough proper CD, representation and all of that, right? Um, and then CBC, maybe some PCR testing, and then genetic testing. Now, PCR is important, okay? Because what are you measuring in the PCR? PCR detects something called Tregs, okay? They've mentioned it here. They've mentioned it here, T cell receptor excision circles, but they never talk about what the hell that is. Okay, so we have to sort of focus on what is Tregs. Tregs, we see when we did somatic hypermutation, we saw the VDJ genes and stuff. Okay, and then how we saw how they sort of combine and recombine and make a different antigenic variations, right? So let's say this is the gene product that it came up with. This is a VJ, so this is basically for a light chain, right? But then you see that the leftovers, right? Basically the introns. Whenever you talk about in genes and stuff, you talk about the things that are going to be showing, which is the exons, and which are or the wasteful stuff, which is the introns, right? So basically, Tregs are the introns of these VDJ mutations and stuff. Okay, they're seen and they can be detected via PCR. You just sort of have these templates and tell the PCR machine duplicate it and you get large copies of Tregs circulating and you can detect them, right? And but usually what happens in SCID, you see low number in SCID. Okay, the Tregs are not happening, especially if you have a RAG mutation or something like that. Okay, all right. So without you see a couple of points that I've written. Without stem cell therapy, they're gonna die within the first year. Right? So it's still a newborn kind of a thing, right? Mother's T cell against fetus, you might show something as graft versus host disease, right? So you see, the mother has the T cells, but the fetus does not have any T cells, right? So you might see that the mother is sort of attacking and making a response against the child itself, right? It's very rare, but I came across this point somewhere, so I've put it here. But you see, SCID can sort of have this graft versus host disease in a pregnant mother. Okay, so stem cell therapy crucial no live vaccinations, and then antimicrobials. Okay, that's the usual therapy for all of these. All right, next comes ataxia. Important, very, very important. Okay, you see, ataxia, and I'm going to give you the page, is a gene on chromosome 11. Okay, this is supposed to phosphorylate TP53, but because of the mutation, it's not going to. Okay, now phosphorylation of TP53 activates TP53, and there was supposed to be DNA repair, but there's no DNA repair anymore, which means that even though the cell or the DNA was like sort of broken and not actually having proper genetic material, when you don't have genetic material, you're not supposed to go and divide. Okay, you're supposed to be destroyed. But instead, there's like a sort of like malignant transformation where you're not stopping the cell cycle, and there's making this like very fragile slash um, you know this damaged cells basically, right? Now, eventually, what's going to happen? You see the physical manifestations, telangiectasias, right? You might start to see cafe au lait spots. This is a very subtle thing, but they might throw it in there. Okay, you will definitely see immune deficiencies because T cell involvement. You might start to see lung disease and stuff as a extra part of it. Okay, just to understand this, we're going to go into biochemistry for a second, and we're going to look at DNA repair. I think um, I think we sort of talked about this, but let me see. Um, yeah, so DNA repair, nucleotide excision. I don't think they mentioned ATM gene. That's okay. What we'll just discuss is the cell cycle that is over here, right? Yeah. So you see how this P53 is sort of working, right? DNA damage. If there's ever DNA damage, right, it's gonna stop the cell cycle and basically restrict any sort of proliferation. Okay. And go into apoptosis and destroy the cell, right? But because of ATM not actually functioning, you see P53 activation does not occur, right? And I also have like this diagram right here. So you see defective ATM, failure to induce apoptosis or checkpoints. Then you see other cyclin proteins like cyclin A and cyclin B. These are not going to be, sort of protecting against like this constant sort of feedback, because these guys were the security guards that were monitoring that, the cell is good to go. The cell, is the quality check is being performed and it's good, right? But now because of these constant breaks and the ATM gene not working, it basically doesn't allow these cells and these different proteins to work. Okay, so that is the essence or the genetics of ataxia telangiectasia, right? Couple of other mutations that you can see along with them is the BRCA mutation, right? So the breast cancer choices, they increase whenever you talk about the ataxia, right? There's the intrinsic factor. No, not intrinsic factor. This is the, I think this is one of the, yeah, protein synthesis factor. Yeah. So this binding protein right here, right? I think it's a transcription factor. This is responsible for protein insulin synthesis in the body. Okay, if this is disturbed, which is commonly seen associated with ataxia, you see that they might have insulin resistance, right? And they might have disturbed growth because of it, right? So these two mutations are sort of seen in combination with these guys, and it sort of explains when you look at, if I go to immuno and you just look at ataxia, you will see that they've just mentioned it there, but for no apparent reason or rhyme, right? For example, um, no, they haven't given it to you. But yeah, in certain questions, you might see something about like insulin resistance or which one of the different cancers can be sort of seen with these types of patients. But yeah, so these are some salient points that I've written. There's also this mutation, which is the ribonucleotide reductase mutation, right? This was supposed to um, actually help in growth of these T lymphocytes and stuff. Okay, but because of these loss of this reductase, you're gonna have abnormal mitochondrial DNA synthesis, right? And once these DNA of the mitochondria starts dying, you're gonna see neurodegeneration starting to occur, right? Constant neurodegeneration starts to occur. That's why you see the abnormal gait, ataxia, dystonia, right? So abnormal contractions. You see something called oculomotor apraxia. That means the eye coordination with the hand-eye coordination and the eye to like mouth coordination is gone. Okay, they're going to see eye problem, nystagmus, strabismus. All of these are going to be problematic. Then you start to see speaking, chewing, and swallowing disturbances. Okay, eventually you might go into not just the Purkinje cells, but you might go into the cerebrum itself, where you might see cognitive impairment. Okay, respiratory weakness, and even maybe aspiration. Right, because of these constant damage and these cells just constantly dividing, you might start to see leukemias and lymphomas getting way more prevalent with the population. Okay, and then just the couple of things that you can do is ATM mutation tracking, and like you see the ATM protein within the body being decreased, right? Couple of main things. AFP, I think this is the most like diagnostic thing about it. AFP is going to be high, while IgA and IgG is low. That's the only two um, like immunoglobulins that are actually low. The other ones are sort of maintained, right? You see, IgA, G, and E is usually low, and IgM is usually normal, which is basically means like the class switching that is supposed to happen is not working anymore, right? All right, so that's that. And then what are you going to do to help them? You see, you have to give them infection management, then neurotherapy, right? Give them occupational and physical therapy, right? Maybe check for malignancies, make sure they can swallow, make sure their pulmonary system has no infections and things like that. Okay, so that is ataxia telangiectasia, right? Now, the problem is that people get confused between Friedreich's ataxia and then ataxia telangiectasia. And trust me, both of them are going to be in the options most of the time, right? Because what are you seeing in both of these? You see, the gene associated is the ATM gene over here, and it's the frataxin gene over here, right? ATM gene as well can lead to mitochondrial mutations and the mitochondrial DNA problems. Frataxin gene exclusively leads to mitochondrial problems. Okay, what is the age of presentation? You see early versus late. Similarities, you see both are autosomal recessive. Both lead to ataxia, right? Cerebral problems, and their onset is in childhood, right? We see the physical deformities in Friedreich ataxia and the spinal degeneration is the thing that makes it much more, um, you know, easily identifiable, right? Then you see there's only immunodeficiencies in this guy, okay? Only malignancy problems in this guy. So you see that's the main thing. Physical deformities, right? Physical deformities and spinal degeneration. Okay. While the immune deficiency and malignancy problem in this guy. Okay. They like to ask cause of death. Heart problems, hypertrophic cardiomyopathy. That's how they die. Right? How do these guys die? Maybe respiratory infections, chronic respiratory infections, or malignancy, leukemia, lymphoma. Okay. So make sure you understand the difference between the two. All right. Now we can sort of wrap it up with the other two, which is hyper IgM and Buscola Aldrich. All right, let's get into it. So hyper IgM, right? IgM is happening because you're not performing class switching, and to perform class switching, you have to have like this co-stimulator protein, right? CD40 ligand is not actually binding properly anymore. Okay. Now, if that isn't sort of happening, you start to see certain infections happening. See, T cells are generally functioning, but IgG, A, E, all of that is lost, right? And the second thing you start to do is cause B cell dysfunction. Okay, so you see B cell dysfunction leads to autoimmunity, right? So it's important for you to sort of write down that which one of these immune deficiencies leads to malignancy, which one of them leads to autoimmunity, and it'll be easier once you get these notes on your hand. Okay, so it'll be easier once you do this, but make sure you summarize whatever is being taught. Okay. All right. And then thrombocytopenia can also be seen, and neutropenia can also be seen, right? What are the typical organisms that you're going to see? Pneumocystis. You see, all of the opportunistic infections are going to come here, right? Cryptosporidium. You see, most of these were seen with like, HIV and stuff, right? Like late HIV presentation. CD4 cells are decreasing. but now you're going to see this early on in IgM. Okay, strep pneumo leading to otitis media, sinusitis, etc. Right? Do they have any other points? You see class switching, again recessive, right? Everything else is decreased. Germinal centers are lost, right? So all of these are lost here. All right, so now we understand IgM syndrome. Last one is Wiskott-Ulrich. Okay, very interesting thing. What are you doing here? In this case, you have this mutation in the WASP gene. Okay, WASP gene, right? Now the WASP gene, if you look at here, it is also directing cytoskeletal elements. Okay, we've also seen cytoskeletal elements just to see over here. Okay, lysosomal trafficking, microtubule dysfunction, right? So this cytoskeletal element and this sort of sort of look alike, right? Both of them, if you look in deep, where they start to cause um, thrombocytopenia problems, they all start to cause some sort of neurodegeneration as well, right? Most of these guys, you see the typical presentation, again, greater than 2 years old. Usually it's X-linked, so it's a male. And then what do you see? You see infections, you see thrombocytopenia, you can see atopic presentation, eczema and stuff, and then you will see autoimmune disease. Okay, eventually, right? Eventually. So what does the sort of complaint of the patient will be? Bruising, bleeding out, right? Bleeding out. But then they have the atopic presentation, right? Plus the infection that they already have from other places. Okay, and if you need to see how this sort of presents with why is this happening in the platelets, right? So this is how the platelets sort of develop, right? Hematopoietic stem cell, megakaryocytic progenitor cell. Eventually, you get a megakaryocyte, and the mature megakaryocytes makes these branches, right? These branches are supposed to break off and make these small fragments, which are platelets. Okay, that's how these are supposed to work. But because of the WASP gene mutations, these cannot break away, right? So you don't get the platelets within the system properly. Okay, and that leads to decrease in number of the platelets, leading to bleeding, right? That's how you explain the bleeding, right? And because of the different sort of B and T cell disorders that are sort of happening, right? You see the infections and the eczema and stuff. Okay, how do you? And this is another like presentation. You see platelets, right? These are the small platelets that is being seen here, right? These are very few in number, and they're like not actually working that well, right? And I'm pretty sure I think this is like some sort of giant like megakaryocyte and stuff. You're not supposed to be seeing this. Okay, so that is one of the thing, and you see how do you sort of fix this? Peripheral blood smear, you're gonna see small and low number of platelets. With what you can do to confirm is do some genomic testing or flow cytometry. We've seen this in every one of them. Okay, we've seen this in every one of them. It's gonna happen every time, right? How do you fix it? Antibiotics and hematocell stem cell therapy, or you can give them IVIG to sort of get the T cell functioning, right? Or you can perform surgery, splenectomy, or platelet transfusion, sort of to manage the how much the platelets and other things are being destroyed, plus supplement some coagulation proteins and stuff. Okay, so that was the entire immunodeficiency, in one class, right? So, in the next couple of meetings that we'll do, is we'll sort of work through all these different questions and presentations and stuff. And if any of you have any doubts, you can bring it up to me, and we can get the stuff done. Okay. Next thing I'm sort of planning is like maybe I'll go into Gen Farm, right? Gen Farm is a big problem for everyone, and even maybe like GenPath. Okay, so everyone, I hope everyone is on the same page and will get those systems done too. Okay, all right.